Good morning, everyone. Welcome to the second SEOW quarterly meeting of 2022. My name is Laura Johnston. I'm a Policy Research Associate with the Pacific Health Analytics Collaborative, or PHAC. That's at the University of Hawaii Center on Aging and Health. I'm also working with Dr. Dan Cielo Subia, who's here with me today, Taki Farahashi, who's also in the room, Iran Terada, and Idra Ha.
Hello, everyone. So my name is Benjamin Chu, and I'm a graduate assistant on the State Epidemiologic Outcomes Workgroup for PHAC, along with Dr. Victoria Fan and Lynn.
Okay, so to start off this meeting, I'm going to go over the agenda and the speakers. Okay, so first off, we'll have a welcome and brief introduction of the SPF, PFS, SEOW, and SCPW. We're excited to present a data presentation today, which will be introduced by John Valera. John Valera is the acting administrator of the Department of Health, Alcohol and Drug Abuse Division. He's worked at ADAC in various capacities since 2016. Prior to that, he was a planner for the Department of Health Environmental Management Division. He also has a master's in urban planning from the University of Hawaii and has earned a bachelor's in science in planning and public administration from the University of Southern California.
Okay. And also Jane Onoe, it will be presenting on the 2019 to 2020 Student Alcohol, Tobacco, and Other Drugs survey. So Dr. Onoe is an associate professor in the research division of the University of Hawaii Manila at the Johnson Department. For the Department of Psychiatry, and has been involved in several projects funded with Hawaii Department of Health, Alcohol and Drug Abuse Division, or ADAD. So Dr. Onoe has also served as a principal investigator for the Hawaii Student Alcohol, Tobacco, and Drug Use Survey, and which is a statewide school-based needs assessment for youth alcohol and substance use prevention and treatment. And so on top of that, she also serves as a director for the System of Care Applications for the ADAD State Plan Project.
Okay, great. So after that presentation, we'll have a brief Q&A. We'll then have a 10-minute break before we roll into the second half of our meeting today. And then we'll start off our second meeting with an introduction by Tehani Diaz. She is the Strategic Prevention Framework Partnership for Success Coordinator for the State of Hawaii Department of Health, Alcohol and Drug Abuse Division. She also has a master's in public administration. And then Cielo and myself will be presenting an overview of the SCPW, followed by another Q&A session, and then some closing remarks before we wrap up the meeting. Okay, so let's start off with a brief introduction of the SPF, PFS, SEOW, and SCPW. Next slide, please.
Hello, everyone. Okay, so the SEOW is part of the Hawaii Strategic Prevention Framework Partnerships for Success, which is a federal grant funded by SAMHSA, or the Substance Abuse and Mental Health Service Administration. So the purpose of this project is to strengthen and enhance Hawaii's prevention system to promote well-being and reduce the impact of underage drinking amongst people with ages 9 to 20 in Hawaii's communities. So the SEOW is a partnership between the Department of Alcohol and Drug Use Division, or ADAD, the University of Hawaii Center on Aging, which is where we have the Public Health Analytics Collaborative, and interested community stakeholders. So the SEOW has been providing epidemiological services to ADAD since 2006. And the SEOW collects and analyzes reports, substance use incidents and prevalence, as well as provides technical assistance for training and state community stakeholders.
Okay, great. Thanks, Ben. As part of the SPF PFS, the State Community Partnerships Workgroup, or SCPW, supports academic and community partnerships that increase the capacity of substance abuse prevention system to address local needs. The SCPW achieves this by conducting applied research, which address alcohol use among high-risk populations. Most recently, the SCPW released an alcohol tax policy study working with community partners. And the SCPW also supports the goals of the Hawaii Strategic Prevention Framework Partnerships for Success, or SPF PFS. So that's a brief introduction to the SPF PFS, SEOW, and SCPW. Before we roll into our speakers, I just want to make a note here that we are in person and Zoom. So this is a hybrid meeting. For those of you on Zoom, it may look a little different from the meetings that you're used to because this is a Zoom webinar. So panelists and other participants can't see you, and attendees also cannot see themselves. So if you want to ask a question or make a comment, just use the Q&A feature. It's located on the bottom middle of your Zoom screen. And you can post questions or comments in there at any time, or you can wait until after the discussion. When we take our questions, you can type them in then as well. That's totally fine. Okay, so with that being said, let's move on to our speakers. So without further ado, please join me in welcoming John Valera and Dr. Jane Finlay.
Okay, good morning, everyone. Hope you can all see me. I can see you. Congratulations to all of you for returning to more of a hybrid and meeting in person again. This has been a long time coming. For several years, we've been sequestered, but it's great that we can at least do hybrids once again. And I hope to join you in person soon. I'm John Valera. I'm the acting administrator of Hawaii Alcohol and Drug Abuse Division since early December. I'm here I don't really have a PowerPoint, so you're going to basically see a talking head, but I'm here to just offer introductory remarks into the work. Dr. Inoue and if Dr. Tyann Miao is here as well. I just want to give her credit where credit's due, as well as Dr. Susanna Helm and Dr. Deb Gobert, who was instrumental as a consultant throughout the whole process. So the ATOD study for school year 2020 is essentially a revision of a 2006 ATOD study. And the Department of Health basically felt the need, okay, we've been using this data, citing the 2006 study as it gave estimates on need for public school students, treatment need, those who are affected with substance use, probable substance use, back in 2006. But as you know, times change, and what was once the assumptions that maybe perhaps held true for the 2006 study do not hold true for today. So we asked, well, the 2006 study involved conducting a student prevention treatment needs assessment survey to measure substance use and risk protective factors among public, private, and charter school students. So it's not just public school students, in grades 6 through 12 in Hawaii. And so the UH was brought on, came alongside ADAD to conduct presentations to school and community groups on the findings of an earlier 2003 survey, and talk about the 2006 survey that they were going to undertake at the time, as well as substance use regarding risks and protective factors. So they were also to recruit public, private, charter schools with students in grade 6 through 12, conducted the survey, did a pilot test of students conducting the survey online via computers at the request of public, private, or charter schools, did a brief feasibility report, analyzed data from the earlier 2003 survey, did the survey, drafted protocol for the survey, met with ADAD staff at the time. I was in another program, so this is a bit of a history lesson for all of us, and implemented the survey, did reports, interim reports as well as a final comprehensive report. And what they found was essentially that at the time, they found that for treatment needs by gender, more females than males met the criteria for abuse or dependence for any substance use. That was the first thing. The second thing was with respect to treatment needs by grade, about 1.5% of sixth graders, under 5% of eighth graders, and 10.5% of 10th graders, and 17.8% of 12th graders met the criteria for substance abuse or dependence. They also found that adolescents most likely to meet criteria for substance abuse or dependence were Caucasians, around 11.5%, and Native Hawaiians, around 11.1%. Also, students who identified as other ethnicities, around 11%, had higher rates as well. But it should be noted that the study said that the sample size for other ethnicities was not as large as that of Caucasians and Native Hawaiians. In addition, about 7% of students of other Pacific Islander ancestry also met criteria. Japanese, about 5.4%, and Filipinos, 4.7%, had the lowest rates. The 2006 study said at the lowest rates of needing treatment for substance use. Okay, fast forward to today, actually around 2019, when we first worked with Jabson's Department of Psychiatry and met Doctors Anoy, Helm, Gobert for the first time, at least my experience. We sat down and we agreed to do an update as it was sorely needed. So they were to do an ATOD study for school year 2020. All this planning was done pre-COVID. We did not know the impacts that COVID would have on it. But they were to measure substance use risk factors and protective factors among public school students in grades 8, 10, and 12 throughout the 2020 school year. So they looked at the previous ATOD survey, which the intent was that it would update. Of course, the study parameters from the outset, we understood that the study parameters would not be identical to the 2006 ATOD survey. So it began around early January of 2019 and ended late 2021. And so what they did was they updated the survey method, and here are basically the differences in the school year 2020 ATOD survey. First of all, they changed the survey method. It was primarily administered in an online format instead of a paper pencil format in public schools, selected through a sampling plan. However, paper pencil surveys were available as a backup. There was no sampling of grade 6. The team felt at the time that because of low sample sizes from the previous survey, it was just more resource intensive than they could handle or had the abilities to. And so we agreed, okay, let's just focus on grades 8, 10, and 12 and focus on that because the response rates were better. Was more cost effective, excuse me. And then the third thing was the sampling plan was done by community regions versus specific schools. They obtained representative samples of 8th, 10th, and 12th graders at the quote unquote community region level instead of specific schools, whereas community regions were somewhat identical to DOE school districts for most of the state. whereas for Maui, each island is a separate community region. And so they, again, cost effectiveness played into this parameter. Another thing was to include a high need, what was called high need or low resource schools. The sampling plan also included schools with identify high need or few resources as part of the sample study if such schools were not selected randomly at first. So it was a sort of a 2-cycle selection in the sampling plan, random selection plus the inclusion of the high need, low resource schools, primarily in the rural remote areas. Hana on Maui, Pahala on the Big Island, that sort of thing. Another difference was public school student participation. So it was based, the 2020 ATOD survey was developed on passive consent, also called opt-out procedures, adopted by current Hawaii school health surveys, as well as the youth risk behavior survey, use the same opt-out method. They were early on, they were in discussions with DOE to decide, whether opt-in could be used, or if DOE wanted them to use the opt-in method. In which case, the UH team would adjust their methodology accordingly. And the reporting was done by this community regions as well. And it was understood that as part of the relational design methodology that they UH used, that each school would have a report. Participating schools would get their own school report. We would not get those, but it's more, we would get more of the statewide, the county region, and as well as the sub-county / community region reports, which are now available on our website. The need for it was, this study occurred in 3 phases. Planning and preparation phase, which was basically the first half of 2019. Implementation, which took us from July 2019 through mid 2021. And then dissemination phase, which kind of occurred for the rest of 2021 until late 2021. The main, ADAD felt that this 2020 study was needed because data at the time, more recent data, seemed to cast doubt on the relevance of the 2006 ATOD study. For example, from FY15 to FY18, Native Hawaiians represented about 42 to 46% of actual adolescent admissions to treatment, which was over 4 times the rate for adolescent Caucasians. Whereas the 2006 study suggested a slightly higher prevalence of Caucasians over Hawaiians, which the actual data from FY15 to 18 did not support. The same FY15 to 18 data showed that Filipinos have a higher percentage of actual admissions than Caucasians, which again, the 2006 study did not support. In the 2006 study, it said, that this ethnicity had the lowest rates for substance use. And so we felt the need to just update. It's time for an update over, it's been over 10 years. And I'll just 30 more seconds and I'll wrap up. But the 2006 study also did not sample for substances that since that time were introduced across the mainland US and slowly making its way to Hawaii, such as opioids, e-cigarettes, electronic nicotine delivery systems, prescription drug abuse, and fentanyl. And at the time, ADAD received anecdotal amounts of accounts of polysubstance use rising among adolescents. Therefore, a revised ATOD study was needed. It was also needed because we needed to update the research protocol. The 2006 study was based on the DSM-4 criteria, which is now outdated. And furthermore, the body of research for the 2006 study referenced sources from the 80s and 90s, but did not take into consideration the latest research into risk and protective factors for adolescents with substance use. So there were multiple reasons for us to undertake this important study. So I gone a minute over time, apologize, but let's either hand it back to our hosts or Dr. Inoue.
I can jump in. Thank you, John. That was an amazing, wonderful sort of context and background. Appreciate you providing sort of that background for folks. And I wanted to share screen, so I am not sure if perhaps I can, oh, there we go. Let's see. I can go ahead into the sort of the highlights of the Hawaii Student Alcohol, Tobacco, and Other Drug Use Study, or ATOD survey. So I wanted to just kind of segue that, you know, John, you mentioned the relational design, I think, and all of this preparation and planning and the need for this update. But I did want to extend my appreciation on behalf of, you know, the psychiatry, UH Psychiatry, and the team, that our collaboration, I think, also produced the opportunity for innovation. As you mentioned, fast forward 10 years, you know, there were some updates that were needed, but there was room for some of those innovations that you talked about, being able to do the survey online, and then also work with actually community-based field site coordinators that were instrumental to, I think, having a very robust participation of the schools and engagement of students as they were taking the survey. So I wanted to acknowledge, of course, ADAD for their collaboration and partnership, and then also the DOE for their approval for conducting the survey. The current dissemination activities are supported by psychiatry as well as Queens Medical Center. The views do not necessarily represent views of sponsoring partnering agencies. Please refer to actually the reports that are on the ADAD website for more information about again, the background context, the relational design aspects, the sampling, the methodology, and the limitations, as well as some key takeaways and implications. And then most importantly, I think really that this survey would not have been possible without the support of the individual school administrators, staff, and students who actually made the project possible. And then of course, our very large team of students and staff that helped to make this project a success. Oops, let me go back, oops. Okay, so the timeline, as you mentioned, John, there was a preparation and planning. We did, again, leverage our field site coordinators that were based on the community, especially on the neighbor islands. I think that made an important impact in terms of outreach in preparation for the fall survey administration in 2019, and then all the way through to 2020. Where we actually did do administration of the survey until the COVID-19 shutdown of the schools. And then thereafter, there was a phase in which we did, you know, some of the data entry from the paper pencil versions, cleaning and merging, coding, and analyses, and then the reports. And then finally, we continue on to our dissemination to the schools, as well as our continued broader dissemination. So thank you for the opportunity to do that today. In terms of the methods, just overall, really just briefly wanted to lay out that with the weighted sample from that sampling frame that John had described, we had roughly over 8,000 student data available to analyze from 8th, 10th, and 12th grades. We did sample at the community region level for island representation, which included high need but under-resourced schools and areas, and that this did occur in that school year 2020. Again, the relationships of our community-based field site coordinators, I think, was a particular innovation. They also were part of the team that when the surveys were actually administered, these were done all by our collective ATOD survey team. Other previous administrations, such as with the 2006-7 ATOD survey, which actually was part of that team along with Dr. Gabriel. She was the PI at the time. Those administrations involved a different sort of approach, which was more traditionally training the teachers to administer the survey. But in this case, we felt that having the field site coordinators and our own team there to administer the survey would reduce the burden on the teachers. We did work with a school liaison to coordinate and to be able to do the administration and the logistics about the online survey administration. And so overall, I think this resulted in a very positive participation rate of over 88% across the board. And the report, the state level report also breaks out by county what those participation rates were. And they're all really actually quite good. In terms of the main sort of measures that were in the survey, for looking at risk and probable substance use disorder, since the DSM criteria were outdated at the time. And then we also, felt the opportunity to tweak the survey so that there was room for some other things, including mental health screeners and so on. We came to an agreement that the craft screener, which is actually used by the DOE, and they had been trained on it, for looking at risk and probable substance use disorder, did make sense, as well as looking at, of course, the behaviors around alcohol, cigarette, e-cigarette, and marijuana use. So those are the ones, the sort of the top ones that I'll highlight, but you can find the other substances in the reports as well. In terms of the demographics with grades, 8th, 10th, and 12th, we do see sort of the counties break out slightly in some distributions. Some are a little bit weighted, have more on certain grades, but overall, this is the state breakout for the demographics by grade. Generally, 30-some% on each 8th, 10th, and 12th. And then in terms of gender, so this is also an update to the survey. There was a set of questions that did ask about gender aside from the typical male or female. And so the third category we felt was important to be able to include because of what the literature suggests in terms of risk, risk behaviors for transgender and other gender nonconforming. So we sort of put those together into a gender diverse category based on their identification of sex assigned at birth and current gender identity. So if you can see that there is a small proportion of students overall in the state as well as in the county that do identify in that gender diverse category. But then you'll see why it's important, even though proportionally they are a small group, why it's important that we did ask those questions. And again, for primary race and ethnicity, there was an option for students to select primary, meaning single primary, but also more than one. So actually what we found was that when students were not forced to kind of, box themselves into one primary, the two or more group actually was quite large in terms of the percentage of primary race or ethnicity identification. In looking at that group, we found that among the top race ethnicities represented in that were Native Hawaiian. So we did sort of a breakout so that you could see sort of in a more simplistic fashion what Native Hawaiian versus not Native Hawaiian among the two or more. So if someone was interested in looking at students who had identified primarily as Native Hawaiian, they could actually look at the percentages across the primary Native Hawaiian as well as two or more Native Hawaiian and kind of look at those in some. In terms of, again, the survey, we found that in the literature, and also because of where we are in Hawaii, culture has confers some protection, protective factors. So we did ask about culture, the importance of culture in terms of maintaining cultural traditions, a sense of strong ethnic belonging. And we did find that students did report on those items, that over half, up to close to 60% across the state felt it was important to maintain cultural traditions, as well as around 85% reporting that they had a sense of strong ethnic belonging. Other demographics, so the language other than English in their household, that's also somewhat related to culture in terms of language, so just under 18%. And then we asked also about a place, regular place to sleep other than home in the past 30 days. So across the state, among our sample, 5.5% had reported that in the past month they were sleeping in a place other than their home. And then the educational level of the parents, mother, father, or equivalent guardian, as well as military and living on a Hawaiian homestead or self-family. So you can see those, how those also proportionally are represented in the county and community region level reports, if you're interested. And overall, more than 1 in 10, we found based on the craft screener would be in the sort of range for the probable substance use disorder, that's far more among middle or high schoolers. In terms of looking at that craft screener for probable substance use by grade, we find that from 8th to 12th grade, it more than doubles from middle to high school. And then by gender, this is, I think, where we are starting to see where gender diverse students are more likely to have screened for a probable substance use disorder as compared to their male or female counterparts. And looking at the estimated treatment need, again, based on the probable substance use disorder criteria on the craft screen, we see that the green third column in each of the counties, as well as the state, is that probable substance use disorder category. And then the screen positive is actually the risk screen positive percentage. And then the largest column, lightest colored bar, is the screen negative. Put together, I think we see that there's a range with some counties slightly higher, like such as Kauai County compared to Honolulu or Hawaii County, or but I think, you know, generally we do find that that middle sort of section also, the screen positive, was another a proportion of the students that we wanted to pay attention to, as well as for treatment. We were able to ask a few questions around mental health, and then also for an attention screen, because there, you know, is a lot in the literature that suggests the relationship with mental health and substance use, and then also with attentional disorder. Having risk for substance use and or mental health. So the distribution presented on the left. So the first three columns actually are part of the mental health PHQ-4 screen. And then the fourth orange column is a separate set of questions, which are from the pediatric symptom checklist, which is an attention module. And that actually looks at screening and potential workup or further evaluation for an attentional disorder. But we do see that if you look at the mild, moderate, or severe mental health distress symptomatology reported percent-wise, if you kind of look at the in aggregate or just sort of look all together across the from mild to severe, you are looking at probably over a third of students reporting some kind of mental health distress in current mental health distress from the survey, as well as the behavioral attention screen also showing up at a range from like about 15% statewide, but in some counties being higher, like such as in Kauai County. The relationship of the mental health measure to the CRAFT screen. You can see that on the right side, the figure there, it shows that with the increase in the severity of the mental health distress, you find that there is also a likewise increase in the probable substance use disorder or positive risk for SUD among the students that are reporting greater levels of severity in mental health distress. And then for the alcohol or drug treatment need questions versus utilization, it does look like somewhat of a busy figure, but the key takeaway is if you look at the bottom where you see a large proportion of students that are in the no or low risk group from the screen, there's a proportion of students that are actually engaged in getting help, mostly school and outside of school. And then on top of that, you see these two scales. And then on the left, there's the probable substance use disorder group, of which 29% had reported getting help. And then if you look at the proportion among those who did receive help for alcohol or drug treatment, or that it was mostly half would get help at school or outside of school, and the other half both. And then the remainder of students who screened into that probable substance use disorder category either did not receive help, they reported not receiving help, they thought they should get help, but they didn't, or they just simply think it didn't apply to them. And yet they, according to the screen, they are falling into that category. In terms of the positive risk for substance use, so that was that sort of middle column where you have students not quite screening at the highest end of probable substance use, but at risk. About 16.6% were getting help at the time of the survey. Again, half at school or outside of school, and the other half at both at school and outside of school. And then a large majority, again, either did not receive help, thought they should get help, but they didn't, and or didn't think it applied to them. So this is something to kind of consider in terms of need, perhaps. And then for looking at just the substance use behaviors in the past 30 days, there is a sort of large table here, also in the report, on state lifetime use, current use meaning in the past 30 days, and then also moderate to heavy use. So moderate to heavy use is defined as 6 or more times in the last 30 days, where you kind of think about if there were 6 or more times of use in the past 30 days, and an average that would break out to weekly, but it could be as frequent as daily. You do see that lifetime use is the highest across pretty much all for each of the substance categories. And so it ranges from alcohol, binge drinking, tobacco, cigarettes, vaping, marijuana, and so on, all the way down to other illicit drugs. And then the current use tends to also be high for alcohol, tobacco, vaping, marijuana. So those are really, again, sort of the top use in terms of substance categories. I think it is, in some ways, it's good to at least see the drop in the moderate to heavy use. So thinking about, again, an average from weekly to potentially daily use of substances. For alcohol, it does drop, binge drinking does drop, as well as tobacco. However, vaping and marijuana, in terms of more of that moderate to heavy use, is actually higher than alcohol or tobacco, cigarettes. So again, something to be considering as far as youth substance use behaviors. And this sort of, it just breaks it out by the county level for Hawaii County, Honolulu County, Kauai, which is the county as well as its community region. So there's just a single report for Kauai. And then for Maui and overall for the state. So you can see that in some counties, there is a bit of an elevation in terms of the substance use for that particular category. Primarily neighbor islands as compared to the Honolulu County, which is Oahu. Same with moderate to heavy use. As I mentioned, in that larger sort of grid and table, we do see these drops from current, which is any use in the last 30 days, compared to that 6 or more times in the last 30 days for the alcohol and tobacco. But vaping and marijuana, relatively speaking, are more prevalent in terms of that heavy or moderate to heavy use. So they remain higher than alcohol, tobacco in terms of compared to the any use. And then for the by grade, we do see a similar kind of pattern as we did with that probable substance use disorder craft screen. Went from looking from 8th, 10th to 12th grade. Certainly we do see that increase in the percentage of these alcohol and substance use behaviors occurring. So by 12th grade, we do actually see quite a bit of increase in terms of behavior compared to the middle school at 8th grade. And by gender, so again, this is where the transgender and other gender minority or the gender diverse group is showing higher rates, relatively speaking, for a small, proportion of the student population, that in terms of just across all the substances, whereas their male-female counterparts may be more typically using, again, sort of those top, 3-4 substances. For other substances, we do see higher rates from the gender diverse group. And then by ethnicity, race, again, using that primary identification of the race ethnicity, as well as the 2 or more group, we do see that there is actually higher reported alcohol and substance use among Hispanic, Native Hawaiian, other Pacific Islander, and then that 2 or more group. And it surpasses some of the other groups as well. So again, there's some limitations because, again, this is a self-identification. So it doesn't mean necessarily that they were not of other race or ethnicity categories, but it was based on what they self-reported as being primarily identifying. This graph shows sort of the path of initiation of substance use by age. So in asking students from middle school through high school whether, what their the first use of a particular substance was, we find that substances like alcohol there's an early initiation there. Vaping, tobacco are more often reported being first used under the age of 13. So early initiation is 13 or younger, so it's around middle school. And then we see some other behaviors peaking a little bit later, like binge drinking, although there is sort of a bimodal peak when we look at alcohol use. So some are getting access and trying alcohol at an early age, but certainly, again, sort of that middle school age range is where a lot of the initiation starts to peak. Kind of going back to culture, we do see that there's some relationship potentially that could be explored in terms of the protective factors of culture. But we're looking again at the moderate to heavy use. So for individuals who speak a primary household language that's other than English, so not English, they're showing slightly lower percentages of reporting of alcohol, tobacco, vape, marijuana. Again, sort of the top most commonly used substances. And then for the sense of strong sense of ethnic belonging, those who strongly agree that they had a sense of ethnic belonging versus those who strongly disagreed. In some particular cases, there seems to be sort of a downward slope showing that they're less likely to use those particular substances on a moderate to heavy, that's 6 or more times. In terms of how they get substances and where they use substances, this was also, a question, because I think schools in particular, administrators were kind of interested in trying to find out where these access points were and where they were using it. So perhaps not surprising, at least to them when we reported back out, is that things like substances being given to them were most commonly reported for alcohol, marijuana, tobacco, vaping, and then for marijuana, tobacco, or vape, that was, getting it while at school also was one of the more common ones, as well as giving money to buy it. Taking alcohol from a family member was also commonly reported, as well as looking at where they use substances, usually in a home, their home or some other home, at a party. Some substances were used more frequently at a public place or at school property. So again, the administrators at the school did sort of let us know when we went in to do the survey, and probably when we would report it back out to them, that the tobacco vaping in terms of use on school property had been a problem. So I think that was not a surprise to them. And then looking at some specific items around education and messaging for prevention, 85.7% of students said that they received some type of prevention education, primarily from their family or at school, and that they had seen or viewed some kind of public awareness message. That's about 84% overall. And the modalities in which they had seen those public awareness messages or heard them were commonly around TV or internet channels. So I think, again, thinking about updates and where we are today, a lot of the youth, their TV is different perhaps from 10 years ago TV, but so that idea of TV or internet TV type channels, and then social media apps, as well as their devices showing ads, and traditional printed media like posters and signs. When asked if they thought it was safe for women to drink regularly, meaning daily, weekly, or even occasionally, about almost 10% of students thought that that was okay. So this may indicate some targeted education for prevention around prenatal alcohol exposure might be worth considering. We wanted to take, again, this opportunity for innovation and look at modeling informed important factors using the socio-ecological framework. So looking at these domains from individual, family, peer, school, and neighborhood and community to see where these items, again, the survey was bolstered for these protective items. We want to look at protection as well as risk. And then we found that in this sort of profile of these important factors from the modeling approach, if we were to kind of map those out, we see that certain protective factors like in the community domain around encouragement in the community and positive social norms, their peers enjoying school, whether they found the school climate to be enjoyable, getting support from the family by being able to talk to them if they had a problem, if there were clear rules and consequences about using alcohol and drugs, and an individual level, if they themselves had perceptions of disapproval around substance use, or if they were doing well in school with academic achievement. Those all were in the protective sort of range for looking at factors that were important for looking at problem substance use. And the risk side, we found, again, on the community level, ease of access to substances, whether the students thought there was substance use in their neighborhood, as well as crime or drug selling. On the peer level, looking at factors about friends and their peers using substances around them or offering it to them, those offers, as well as their peers approving of substances. On the family level, looking at exposure to alcohol use by parent or relatives, marijuana use, or have lived with someone that had a substance use problem. And individual, there's actually a couple items that are listed under the individual domain, although they are related to school, like suspension or expulsion, skipping class, and then other ones related to mental health, like such as depression, or having done something crazy, even though it might be dangerous. So these were the types of factors that were emerging out of the modeling. And this sort of very busy but complicated figure, I think, also is in the report, but the idea to kind of look at this is to look at adversity that folds into reducing resilience, because you have both adversity and resilience, but factors that are weighted, there's these numbers attached to them that actually feed into the overall construct of adversity, such as in the community where there's community crime or fights, and then factors that feed into resilience, such as the validation where the individual's youth as well as the community both sort of matching up on the pro-social beliefs, feeding into resilience. Those help to bolster resilience by a certain weight. And this is a sort of more of a prevention, so any current substance use. So these are factors that might have some potential insights as to looking at approaches for prevention. Takeaways, again, overall, about 11% screening for probable substance disorder and 14% additionally for positive risk. Treatment needs seem to double from middle to high school. Gender diverse students at the smallest proportion, but at highest risk. Students primarily identifying as Native Hawaiian, Pacific Islander, Hispanic, Latino, more likely to have a probable substance use disorder based on the cross screen, as well as to have reported using alcohol, vape, and marijuana in the past 30 days. More than a third of students are endorsing some kind of mental health distress from mild through severe, which is also associated with having a probable substance use disorder. Less than a third of students in that probable substance use disorder range reported receiving help, and that may be school and or outside of school. In terms of substances, alcohol, vaping, marijuana were the most used in the past month. And then also substances that students more often try before age 13. There is a common acquisition of these, common substances by being given it to them, as well as giving money to buy them, getting it at school, taking it from a family member. Substances, again, like alcohol, tobacco, vapor, marijuana, are often being used in their home as well as someone else's home, in public places and at school, and then potentially when riding or driving in a vehicle. Large majority of students are getting some kind of substance use prevention education and messaging. And then they're getting it through various types of modalities. I think this is the technology age we are in, but also through traditional printed media as well. And also through education and conversations. I think that prevention education, again, from their family as well as at school. The risk factors that we looked into the modeling helped to kind of inform the domains that contribute to adversity, but also that resilience factors like community validation of that pro-social belief about not using substances, and the school climate and relationships and self-efficacy and cultural connection are important for reducing the likelihood of substance use. So some possible implications, school and community resources for addressing vape use. I think we did hear that as well. We had talked with the schools looking at outreach and monitoring for the gender diverse students, screeners around mental health and behavioral health integration to address co-occurring issues, prevention efforts around that early initiation point, and then integrating culturally based approaches, perhaps into prevention and treatment for enhancing resilience and improving care. And so I think that is all I had.
Okay, great. Thank you so much to John and Jane for those incredible information and presentation. Okay, so we do have a few questions already in the chat and in the Q&A box. So we're going to go ahead and start there. Our first question is there a way to get the substance use data for youth who are part of military families? In the ATOG reports, it shows the demographic category family member in active military, but there's no substance use data reported for that group. They have unique risk factors that should be taken into consideration for prevention, intervention, and treatment programs.
Yeah, so I think that so what I'm presenting today comes from the report, so that's correct. That's not one of the areas that it's reported specifically around military. But we do have the demographic, so I think that would require some additional analyses. So there's a potential to be able to report on that, but we would have to go through a couple of approval processes to be able to do that. So I think that's something that we would need to circle back to. But thanks for asking the question, because I think we have a slew of things that, of course, as researchers, we want to kind of follow up and see and do a little bit of a deeper dive. So I would appreciate if we could come back to that at some point as we continue our dissemination efforts and analyses.
Then, if I may, I would like to address the question about the essential element for promoting some collaborative research with multi-stakeholders. Based on how I was trained, I think having that, taking somewhat of this relational design approach that UH has done, where the idea is to involve as many stakeholders that should be involved as early as possible. And it involves, since early 2019, there was a lot of meetings, a lot of communication, a lot of, and being transparent, involving as many stakeholders as possible, as early as possible. And that's something that really appealed to me when we approached Department of Psychiatry about how to go about this. And they did the initial 2006 study. So I think we just hit it off really philosophically from the get-go. And there was a lot of meetings where different technical points, say around the sampling plan, were discussed, even debated. And psychiatry also, Dr. Inoi's team did substantial interaction with the schools and got buy-in, not just with their coordinators, but their administrators, complex area superintendents. And so this is perhaps one of the most collaborative efforts that we've seen with the DOE in quite a long time. And thank you to those that really believe that that this update was needed. And we do hope to continue this effort again in the future. The Department of Psychiatry wishes to undertake a similar update in the future. I'd be interested in supporting that.
Thank you, John. I think it was, again, like you mentioned, it was due to sort of that collaborative spirit that I think helped to produce this. So appreciate it. Do you want me to go ahead and answer that one other question about the ACEs?
Sure.
There's a question here about, any surprising results we were not expecting in advance during the preparation stage. I think we had no expectations because it was actually the first time we were doing something like this. So it was actually, we were kind of understanding and learning as we went along. Again, that's sort of the flip side of innovations, is if you're innovative and you're doing it for the first time, you're not really quite sure what to expect. But in terms of results, I'm not sure that anything was particularly surprising. But also I think in terms of the ACEs, we did, we were in sort of that consultation early phase of the development of the survey, we did talk about ACEs. And because, again, this was in a survey that we had to try to administer in a class period or even shorter. And so we kind of did actually a number of rounds looking at what items ultimately ended up in the survey. And among the ACEs items, the one that actually had the most relationship, I think, to substitutes. So I think that's one, the item about having lived with someone who had substance use history or problem, worded slightly differently. Then I think that was the one that we did end up using. But I think as perhaps future iterations are unroll in the future, perhaps those are the kinds of questions that may be needed to look more deeply, again, sort of at the adverse childhood experiences. So I think, your feedback and reactions to this round would be really helpful. Thank you.
Okay, great. Thank you for your questions. Do we have any questions in person? We'll wait to see if there's any more online. Yes.
Hi, yeah, really great study. I was curious, it was an online survey?
Yeah, it was designed to be primarily online. And then again, the caveat being is that we approached the schools requesting it to be online. Ultimately, we did end up doing paper pencil administrations. Some of the reasons behind those were because they're just simply weren't, the logistics made it not possible. So whereas, some schools had access for all students sampled to be able to do the survey online, other schools were like, well, we just can't get the computers from, like a core class to this particular class or whatever. So we ended up having to work with the schools to coordinate what was the best approach. So in all, I would say majority were done online, but some were not. And then we actually had, things happen where there was an actual island-wide internet outage during the day of a survey. And so we had to have the paper pencil as backups, which fortunately, we were able to do things like that to be able to kind of, pivot right there on the spot. Yes, regardless of at online or paper pencil, our staff were actually there present to administer them.
I have a question. So first of all, let me say thank you, Dr. Nani, for the presentation. I got a lot out of your study. So one of the findings that I found that was really interesting is that from the sources of alcohol use, it seems like people are reporting it more from utilizing at home. So I was wondering, do you think there could be some sort of like systematic error that is attributed to like reporting bias? So what I mean specifically by that is that I would expect that from other events that people would frequently utilize more alcohol than they would at home. So that's something I was a little bit more curious about.
Sorry, could you repeat that one more time?
Oh, sure. I can talk a little louder. Okay. So one of the results that I found that was really interesting is that for these children, they frequently source that their primary source of alcohol was at home relative to other locations, such as parties or other events in schools. So I thought that would that be, do you think there could be an issue of like systematic error due to self-reporting bias?
In terms of using alcohol, reporting that they're using alcohol and other substances in their home.
Right. Yeah.
No, go ahead.
No, I just thought it was interesting because I would cite that it seems like that was a large portion of them using at home relative to other locations. So I was wondering if for children when they're reporting their alcohol use, maybe they're not honestly reporting from other sources as well.
Yeah, that's a possibility. Although when we're looking at how they are receiving or getting the substances, they are reporting that it is being given to them. So whether it be in their home or someone else's home, it's possible, again, it could be an access issue, and that it is reflecting that access is more commonly available because they're in a home with where the actual substances are present. But I think what you said makes also sense is perhaps there may be other sources as well as it's actually any of the below kind of multiple option response. So I haven't seen, we didn't analyze it to see if like students who had reported home were not reporting other locations, and vice versa, other locations not reporting home, or both. So that might, if that's something of interest, I think, we might be able to look at that. But I think generally it does seem that even from the types of other questions, I think it's suggesting that substance use, access, and use is sort of it's a relationship with other people. Right, so.
Nevertheless, the findings were truly interesting. So thank you for sharing that with us today.
Thank you for your question.
Okay, so I don't see any other questions in the chat. In person, I think we're okay. Okay, so if no more questions, we're gonna move on. Thank you so much again to John and Jade. Really fantastic presentation. We're gonna move on to our 10-minute break before we transition to the second half of the meeting. So feel free to stretch, relax, get a drink of water. We'll come back in 10 minutes at 10:21. Okay, welcome back, everyone. I hope you all had a good break. We're going to move on to the second half of our meeting. So first up, we have Tejani Diaz, who's going to give an overview of the PFS. She is the Strategic Prevention Framework Partnership for Success Coordinator. So join me in welcoming Tejani.
Good morning. Thank you. So yeah, as Cielo said, I am overseeing the PFS grant from ADAD, and we received that funding from SAMHSA. And I have a little bit of a PowerPoint presentation to go through with you guys. Okay, so like she said, it's a bit of a mouthful. Strategic Prevention Framework Partnerships for Success is the name of the funding that I received from SAMHSA. And I work with quite a few different groups. So from UH and an outside advisory committee that I can show you on the next slide when we get that up and running. Yeah, so basically the EPI team is part of what is on here right now from UH, SUOW, SPAW, SCPW. We have lots of acronyms. Everyone does their own little part in data collection, data reporting, things to support the PFS recipients or myself. We have the SPF eval team, who is also from UH, and they do data collection from what the providers input into our data collection system. And they also provide TNTA to the providers that we have. And then we have a state advisory group on underage drinking, and the point of that group is to provide some higher level recommendations on, focus areas for the grant for the different providers. And then as ADAD, we have contracts with 4 counties, and we have coalition work. So they do policy type work normally. They're broken down by new coalitions and coalitions just by nature of how new they are to the PFS grant and the type of work they are doing in the SPIF process, which I will show you in a little bit. And then we have the evidence-based programs, which are pretty much nonprofit providers providing direct services to youth, and they are also throughout the state. Next slide, please. So SAMHSA is the one that provides our funding. They want to provide funding to prevent and reduce the progression of substance abuse and its related problems. And so the SPF PFS process is intended to build up a system within our state, so that as a state we can address these issues and hopefully reduce the alcohol and drug abuse that's going forward. Specifically, our Hawaii purpose is to prevent underage drinking or reduce the impact of underage drinking among persons aged 19 to 20. So although we do know there are other challenges, alcohol, tobacco, other drugs, our focus for SPF PFS is on that 9 to 20 and underage drinking. And so we want to all work together, collaborate, and so to build, this prevention system for underage drinking. Next slide, please. Okay, so as I said, we have a wide range of different providers, and we recently did a request for proposals, and so we've selected new and existing providers who will be providing services starting 10/1/2022. So we're currently in year 4 of 5 for the SAMHSA SPF PFS grant. And of these listed, everyone is receiving funding except for HPUD. They chose not to apply again for funding, mainly because they aren't wanting to focus on policy work at the moment. And our new grant funding is really focusing on our coalitions doing policy work. So for example, if you've heard on Maui, how they passed the social host ordinance, that was their main goal. So the other coalitions will be choosing to work on those kinds of things. Also increasing the alcohol tax, reducing the limit of alcohol in your system in order to drive. Those are types of things that the policies work on. And then for the evidence-based programs, they often work in schools, or Boys and Girls Club has their own clubs that they work with as well, providing their evidence-based programs. Next slide, please. And so we use the Strategic Prevention Framework, the SPF, and it's this little flower looking thing. And so for example, when I was saying that there are new coalitions and existing coalitions, a quote unquote new coalition would be someone who is coming in at like the assessment phase. They want to identify their local prevention needs, what resources they have, and then they're going to build capacity. They're going to plan and develop their strategic plan, and then they're going to implement. So they're going to decide, okay, we need a social host ordinance in our community. That's what our goal is going to be. And then after that, they're going to evaluate, okay, did it pass? Did it not pass? Like, for example, increasing the alcohol tax didn't pass. So they'll go back, they'll examine their process, see what they can do better next year, and then pretty much start, maybe not again at the planning phase, but start again at implementation. So it's an ongoing flower, not just, a one-time thing. And then always including the sustainability and cultural competence. And we don't just mean sustainability as funding, but building capacity, trainings for the staff, workforce development, making sure that people, doing the work and providing programs have the training and education that they need. Same with like the programs and policies having plans for the future of, what they want to do and how they can maintain the type of work that they're doing into the future. And then, of course, cultural competence is always important, especially in such a diverse place like Hawaii. So our providers are always attending different trainings on how to best work with the populations that they're working with in the communities that they work. And that's all for me. That was just a quick overview of the PFS grant. And if you have any questions, you're always welcome to email me.
Okay, thank you so much, Tehani. We'll now have a presentation by Sila Subi and myself. We are policy research associates here with PHAC, and we are part of the statewide community partnerships work group. So we'll be giving an overview of the SCPW. Hi everyone, can everyone see my screen for our Zoom attendees? Okay, Without further ado, let's get started. Again, my name is Cielo Subia. Along with my colleague Laura Johnson, we'll be presenting on an orientation of the State Community Partnerships Workgroup. And again, thank you to Hani for providing that wonderful orientation of the SPF PFS grant program. So an introduction to the SCPW, our purpose and mission, of course, is to aid in achieving the goals of the SPF PFS grant program. In addition, we will provide a sustainable mechanism to support academic and community partnerships that increase the capacity of substance abuse prevention systems to address local needs. In addition to that, our mission is to, of course, facilitate academic and community partnerships by conducting applied research and creating public dashboards which address alcohol use among high-risk populations, such as the homeless population, LGBTQ, Native Hawaiian, and rural populations. So our goals of the SCPW, first and foremost, it's to support the goals of the Hawaii SPF PFS. But in addition to working to develop academic and community partnerships, there are 3 goals within that. The first is to increase the capacity of communities to effectively prevent and reduce underage drinking, substance misuse, and related issues at a local level. Second is to use the SPF to select and implement evidence-based programs, policies, and practices to best address prevention priorities for high-risk communities and populations, as stated in the previous slide. And third and finally, align the prevention systems efforts to sustain community mobilization, collaboration, and the delivery of strategies to prevent and reduce underage drinking, substance use, and related problems in our local communities. So some past and current activities that we have and are doing. Recently, we conducted a joint alcohol tax policy study with the Maui Coalition for Drug-Free Youth and Boston University. So findings from this study showed that with a 10-cent increase on an alcohol tax, it would save lives from alcohol-related deaths, prevent violent acts, provide jobs, create revenue, and be cost efficient. We did previously touch on the alcohol tax policy study in our February quarterly meeting. So we will be providing a link to that recording in our chat later on. And currently, one of our current activities is in conjunction with the SCOW, we plan on hosting these quarterly meetings. So we are planning on having the first hour focused on SCOW, so possibly data related. And then the second half would be SCPW. And along with that, we are working on these 3 current research topics on the right. So our first involves innovative data sources. So looking into Google Trends to inform about public health response about alcohol consumption over time. So we are looking at, through Google Trends, looking at keywords related to alcohol use, such as alcohol poisoning, and seeing if we compare with hospitalization data, if there are peaks in hospitalization data related to alcohol poisoning, as well as alcohol poisoning spikes in our Google Trends. And then in addition to looking into innovative data sources, we are looking into possibly conducting a literature review on the effectiveness of using Google Trends to inform us on this research topic. Our second research topic involves looking at community level characteristics affecting alcohol use. So possibly looking into ethnicity, age, household income, and more. And finally, our third research topic involves looking at adverse childhood experiences. And I will hand it over to Laura to speak more on ACEs. Yes, thank you, Cielo. So one area that we're looking into is adverse childhood experiences, or ACEs. And you can see up on the screen now, these are some categories of ACEs. So abuse can be physical, emotional, or sexual abuse. Neglect, which can also be physical or emotional. And household challenges such as living with a parent or caregiver with mental illness, having an incarcerated relative, parent, or caregiver, a mother who's treated violently or experiencing domestic violence in the home, substance abuse or alcohol abuse of a parent or caregiver, or divorce or separation experienced in childhood. And if you see this pyramid also on the screen, This is just a graphic of kind of the progression of adverse childhood experiences over a lifetime. So we see adverse childhood experiences starting as early as conception and can go all the way through childhood, leading to disrupted neurodevelopment. So there's some research now on what's known as toxic stress. And children who experience these adverse experiences tend to deal with toxic stress, which then disrupts their neurodevelopment. We see social, emotional, and cognitive impairment, adoption of health risk behaviors, which our work group is especially interested in because we want to know how ACEs relate to substance use, things like tobacco use, early drinking. And we're also interested in mental health as well, not only in adolescence, but possibly into adulthood with children who've experienced these adverse childhood experiences. We then see disease, disability, and social problems, and ultimately early death, all the way at the top. So we're interested in ACEs as a risk factor for substance use, and also for other health risk factors, both mental health and physical health, all the way into adulthood. Next slide, please. Okay. And one of our main goals of our work group is academic and community partnerships. So while we have these specific topics that we've sort of narrowed down and we're working on, we're very open to other research topics as well. Or if there's a way that we're not looking at ACEs that would be of a particular interest to a partner, we're definitely open to exploring that. And we want to partner and see how we can assist organizations, what are they interested in, and how can we partner? So, next slide. So these are some of the questions we ask when we meet with potential partners. We ask that partners reflect on their organization's needs and objectives. What questions or problems do they have, and what are they trying to solve and fix? How are they using data and evaluation today in their organization, and how would they like to use it in the future? And also, would organizations be interested in participating in a small group evaluation workshop to help think through how to design an evaluation and collect data to assess the impact of their program? So we're all about asking, what can we do to assist? How can we help and partner? And that can include anything from use of data or research or things like evaluation as well. So please contact us. This is our email up on the slide. And I want to leave this here for a minute, just if you want to take down this email. We're happy to field any questions you might have about data, using data for evaluation, or setting up a one-on-one to meet and get to know each other and talk about how we can best partner and cooperate. Yeah. And the SCPW is fairly broad. We don't just focus on youth or just on alcohol. We are open to, again, other research topics, substance use, more generally, polysubstance use. So yeah, if there is an area that you're interested in or you want to talk about with us, just let us know. Please just contact us and we would love to meet with you.
All right. Before moving on, I'd like to say thank you to all our speakers who spoke in the second half. Tiani, I really enjoyed getting a great overview of the SPF framework, and Celia and Laura have been working extremely hard in trying to produce quality research, which I believe personally will have huge policy implications. So please type your questions in the chat and we'll get to them in the order that they're recorded.
Thank you, Ben.
Thank you, Ben.
Any questions in the chat or in person? Okay, so I see one question in the Q&A for Sehani. Now, would you tell us how to communicate with other states, if any, or SAMHSA to improve the long-term project, the SPF framework? I would like to know about the strengths of SPF in Hawaii relating to cultural diversity and geographical characteristics. Thank you, Tapia, for that question.
Thanks. Okay, so I am still relatively new to ADAD, and I am very new to this field. I actually come from like a nonprofit education and human services background. So I will have to take your question and mull that over, and then be able to get back to you. As far as the, oh, sorry, I just lost the question. The culture, the cultural diversity and geographical characteristics. I'm not sure I totally understand that, but I'll just say that in relation to the like the evidence-based programs right now, they are using curriculum developed on the continent, not locally developed curriculum. So for ADAD, what we're really hoping to do in the near and longer term future is to be able to get more homegrown programs to become, it's not certified, but essentially certified as evidence-based programs, because we know, locally developed programs are going to work well for our keiki. So that's something that I'm personally hoping, to work on in the coming years. But yes, I will take your questions and get back to you.
Okay, great. Thank you so much. Any other questions? The Q&A is still open, or in person as well. I'm just going to wait a few more minutes to see if anything will come in.
In the meantime, is there any questions in person?
Okay. All right. Well, if we have no more questions at this time, a special thanks to our guest speakers. Thank you so much for participating today. And thank you everyone for your wonderful questions as well. We're now going to move on to the closing remarks. So our next meeting is scheduled for August 31, 9 a.m. to 11 a.m. via Zoom. So if you'd like more information on that upcoming meeting, or if you want to register or look at the speakers that we have coming up, you can do that on our webpage, which is now posted on the slide. Also, if you could please take this quick feedback survey, it lets us know your suggestions, what we did good, what we can improve, and it helps us get better webinars going forward. So please, if you can, take a minute to fill out that quick survey. This survey will also be emailed to you after the presentation as well. So for those of you in person, if you want to wait for that email to come in, if you don't have your laptops out, then that's fine. If you could just still take a minute when you get that email and let us know how we're doing. Also, if you have any ideas for guest speakers, if you know someone that would be a good fit for our meetings, please email us. We'd be more than happy to get in touch with anyone you feel like is a good fit. So again, our email is up on this slide as well. Okay. I think that's all of our closing remarks. Thank you so much, everyone, for joining in. And hopefully we'll see you in August. Thank you.